If you want to, sure. Okay, so thank you everyone for coming. Today's educational section is going to be focused on two different areas. First area is medication administration, storage, and controlled substance education. Second area is going to be care of pressure ulcers, different skin issues that we find in our facilities. The reason that we're doing this today is the first topic when it comes to medications is in response to a survey that we have. So we have a complaint survey for both Bethany Meadows and Bethany Home Brandon because we lost 2 cards of a resident self-administered medication, which was a controlled substance. Now we made multiple different policy reviews and made some slight policy changes. So we'll be discussing that as well. So it's very important that we remain focused during this meeting because this is very pertinent information on how to exchange, handle, and administer medication at our facilities. Okay. Can you hear me now?
Yes.
Yes. Okay, good. Move this up. Okay, so to start, we're going to, again, like I said, touch on our medication and storage of controlled substances. Mark Gertis is here. He is from Avera Long-Term Care Pharmacy. They are wonderful partners for us, and he's going to be assisting us with our plans of correction, auditing, and is going to provide some education to all of you today. So please give Mark a warm welcome, and we'll let him give his presentation. Oh, yeah, I'm sorry. I'll follow the presentation. Oh, sure. Okay, there you go. And then you can just click the arrows to move. Yep, I think.
So thank you for the opportunity to come visit today. I get the opportunity to speak a fair amount, and so there's a standing joke at the pharmacy about how many slides I have and how long I can make each slide last. I just told Patty I'd try and leave her 5 minutes at the end because I can go for a long time talking about medication. But I won't do that to you today. I'll try and keep it brisk and keep it going so we can stay on cue. We're going to talk about controlled substances primarily, but receipt, storage, and disposition of drugs, policies, updates, audits. All really, really important. We need to stay on top of these things. When I was meeting with Hunter and Stacy and Katie to talk through some of this, and Cynthia, we really talked about this isn't something that needs to just be a routine process to review these type of things to get in front of them. Just so happens it coincides timing such that state survey process, great opportunity, kind of pushes us sometimes. It's okay. So we're going to talk about these things and put ourselves in a good spot. Just for a little bit of background information. There we go. I think it's always relevant to have a little background because we got into some terminology discussions, and I always think that's a little bit fun. Scheduled drugs, Schedule 1, Schedule 2, Schedule 3, 4, and 5. There are 5 different drug categories that we talk about in regards to DEA-controlled substances. Schedule 1 DEA products are not medically used. So we're going to find things on there like heroin and LSD, high potential for abuse. We know it's a drug, but it's not used medically. Schedule 2 is our highest that we use, hydrocodone, morphine, oxycodone, those types of things. 3 through 5 have lower addictive properties, but still have either euphoric properties or potential to be abused. We have to pay attention to these in high detail for a number of reasons, from a regulatory standpoint, it's critical. CMS, Medicare, who surveys our buildings, says you will have policies on this, you will have protocols, and you will follow them. It's not an option, we just have to have it. The State Department of Health says the same thing. The DEA says it to me, and if we fail in those areas, we can be penalized, lose our licenses, lose our ability to practice nursing, lose our ability to practice pharmacy. They're very serious about this. So we comply because we all like to have jobs and places to go to work. So that's a good thing. So we always like to differentiate one thing that make it very clear to everybody in the room. A facility needs an order for a medication. A pharmacy needs a prescription. They're different. And sometimes you'll get in that bind, in nursing especially, we'll get in the bind where you'll get an order for something, and we'll go, well, we're still trying to get a prescription so we can dispense it, because the DEA has laid additional criteria on what we as a pharmacy need. So we just put that out there just as a little FYI. If you're ever wondering why there's delays, or we're saying, hey, we're still trying to get a prescription for that, they are different. You can have an order. You don't need a prescription. I need both. So there we go. As you're receiving medications, the transfer of a medication from my pharmacy's control to your facility control is a risk point. It's anytime there's somebody's handing off something, there's a risk for diversion, there's a risk for loss, there's a risk for confusion.
Yep. The weakness we had in our survey, so please pay close attention to this about making sure we're signing all this sort of documentation, who needs to sign it, and what information needs to be on there. So please pay close attention to this.
To Hunter's point, receipt is always one of the points of risk. And so, in our discussions, when our delivery guys come, they have 2 copies of the delivery ticket. So you like to sign the one, give it to him so he can get out of there. And you get to sign the second one. Not really an option. It has to be signed. That's the paperwork that's kept here. And Katie and Stacy are responsible for ensuring that they have a tracking mechanism of who received that for a foreseeable future. So as long as that medication is still being used in the building, if the survey teams come in, the process is they'd go, well, let's see how you receive your medications. If they show them a bunch of tickets with no signatures on it, they're going to get funny looks. Well, who took this? How do we know? Well, I know because they signed. So please make sure you're signing both copies so that that is here. Additionally, there's a controlled substance sheet that comes with that controlled substance count sheet. It looks like this, right? All seen it. Please make sure at the time of receipt, some of the stuff will come pre-populated. Some of the stuff on the resident name, others will not. We need it all populated. Please take the time to do that. It's part of your job to make sure controlled substances are handled correctly. 3 major spots in the system that we talk about, receipt and disposition, are the 2 biggest risk points. We need you to do those points right every time. So please make sure that when you're doing that, you're filling in that information at the top, filling it in correctly, and making sure that you put the things into the binder. Yes, ma'am.
Can you please let everyone know what title should be signing?
Absolutely. I'll be happy to do that. Yes, I appreciate appreciate that. And good questions, again, thank you for asking a question, I love it, because that makes my presentation much more engaging when you're there. The person who should sign that is the person who's going to take responsibility for locking it up. You do have to be an authorized person in the building to administer meds, to receive meds. So a CNA who does not have the authorization to do med pass administration cannot sign for those or accept them. Must be somebody who this team has said, yes, you can pass meds in my building to administer. We're working on some policy updates. Currently, Bethany Meadows has some stricter policies on 2 people, either a nurse or 2 med aides. We're working on some policies. So you may get some updates and some less restrictive things to maybe say 1 med aide could do it because they're responsible. Not there yet. So when that happens at Bethany Meadows, Stacy will let you know, hey, it just takes 1 signature to get in. We're trying to get the policy to be a little more consistent with each. But nurse, med aide, as long as they are med certified, can fill out that paperwork and put it into the cart. Count your control. Pharmacy works really hard to try and be as consistent as we can. Every once in a while, there's an extra pill in a bubble, or there's one missing, or there's half tabs in there, and you're signed for 30, but there were half tabs. They're only half tabs, you really only got 15. Make sure you're looking at it, signing it before you sign. When you sign for that from the delivery guy, make sure you've looked at it, counted it first. They will stand there. I think y'all know Dave. He'll stand there happily. He'll chat with you, right? There's the challenge. It's fun. Controlled substances. There should be some sort of reconciliation periodically, and we've been working to get information out to the station PD on a routine basis through Dawn on controlled substances that are delivered into your building just as a reconciliation process. So that is an audit process that's coming in. And into your building, they can go, yeah, that makes sense. I always love to tell stories. Probably 4 years ago, I got pulled into an audit, and it was at a building, and it was the very thing. Somebody said, why did this person get a refill on their hydrocodone? Just one person asking that question uncovered the fact that a nurse had been diverting hydrocodone for the last 6 months, the total of, I think it was 900 and some doses of hydrocodone had gotten diverted. But it took us just one person to ask the question, why did this person get this? Why did that person get that? So reconciliation is important. If and when you're signing for control and the number is not correct, do not sign. Do not ask Dave or who's ever driving to fix that. You have to call the pharmacy at that point. Because it's not right. If it's not right, they can't fix it, and you shouldn't fix it later, and you shouldn't sign for a wrong quantity. But please call us at that point.
There was a question on there. Allison Kirby asked, so med-aids could sign for narcs now.
We will be upgrading the policy. So in your policy, she must be on yours, because yeah, there is no reason not to have a med-aid do that. Now, if you choose to keep that, you'll let them know. But at this point, it does not make sense to us, and to keep the policies similar. They have the keys. So why wouldn't we let them sign? So that was part of what we talked about. Let's get a policy that's easier and simpler. I think that makes sense. If you've got the authority to give it, you may as well give them the authority to receive it. Yes, ma'am.
We are talking about. All right. You then sign it. Sometimes if you do. Yeah, sometimes.
Why are you not allowed to run the fence? We'd love to hear from you. We would love to have you. Our team loves to visit with everyone. So you feel free to call. Our number's right on the card, it's right on everything. You are allowed to call us to discuss questions. Now, we don't, if there's other medical things at the end of it, we're gonna call you nurse to have that. But for functional parts of your job, you certainly should call. We hope we come across as friendly and want to help solve that problem, because that's what we strive for. You also have a question, Ian? Okay. I'm good to that. Yep. So we talked about that, and now we're gonna go into storage. Again, there's three major areas: receipt, storage, and then disposition, or getting rid of medications. One of the things the survey team looks for is to make sure that only designated personnel have a key member. So part of the policy that we will be reviewing and updating will be so that these two always have a list of who's approved. So they should, I asked them a question 2 days ago. I said, how many med aids do you have? They both stopped for a second, but it should be easy because it should be on a list that they should, so you should always have a current list of who's an approved staff. So that nobody ever has the med keys who's not on that list. When I say nobody ever has the med keys, the number one guilty person for having a bedroom key is who? Who's gonna guess? Your maintenance guys. I think it's because they keys everything, right? Make sure they don't have bedroom keys, right? So, and make sure you guys don't give med keys to the maintenance guys. If you did have to get in, you put them in, you watch them, they leave. Storage options. Scheduled by regulation, schedule 2 narcotics. Who remembers what those are? Hydrocodones, morphines, oxycodones. Have to be in a double lock situation, meaning they have to be in the lockbox at all times. In your locked med cart. If the med cart's left open, it's no longer double locked. Very specific regulation. If your med cart lock ever broke, what would you do? Then you shove the med cart into the med room, because you got a lock on your med room, and still have the lockbox on. So, backup systems, always have that. Our policy here will be that schedule 3 through 5, which is tramadol, Ativans, etc., will also be kept in the same situation. Double locked for PRN medications. If they are PRN, they should always be double locked. Questions on that? Because tracking and accountability of that is a much more manual process than the routinely administered. Somebody takes it twice a day or 3 times a day. There's a date and time, very specific regimen to that process. PRNs are counted. And so to track that, they tend to, in my audit processes, PRNs go missing about 10 times as much as routinely administered medication.
No, I think we decided not to keep the scheduled ones in the regular part. We decided to keep those.
Yeah, we're getting to that. So I'm not done. So I can keep going. I told you at the beginning. We're only on slide 4. I can go problem. So I was talking about PRNs must be in. Right now, the 2 buildings have slightly different policies on routinely administered schedule 3 through 5. So your tramadols that are twice a day or 3 times a day, your Ativans, your Zolpidem are scheduled at bedtime, those type of things. Bethany randomly keeps theirs in with the routine meds and follows the medication administration process. Bethany Meadows is keeping those locked, still following the process, but doing it count. That's acceptable. We may try and even that out, we may not. That's fine. But Bethany Meadows right now is keeping the routinely administered ones double up. And it's not bad because it's a little less 24/7 nursing, so it does make sense to potentially keep those double up, especially if it's comfort level of nursing. I don't have a problem with that. Very, very important. This is a must. If you're using the count by date system and not doing a perpetual count, so in other words, the twice a day, then the 3 times a day tramadol, if you're not doing counts on those, you're following date by date, you must report any variance to dates to the director. So in other words, if today is, what is today? 24th. If you're going to give the triangle 2 p.m. on the 24th, and you get to the 24 bubble on the 2 p.m. card and it's missing, that must be reported. If you get to the 22 p.m. bubble and yesterday's medication is still there, reported. Any plus or minus needs to be reported. So that they can investigate. Nobody's in trouble. They just need to investigate. 98% of the time, there's a reason. Hey, we went to the therapy appointment, so the therapist always getting away with our meds. I don't know what to do with it. Yeah, we're ongoing. We're using the system, and what the regulation says is you must have a system of accountability. Most people do. You can either do a system where you go, everyone has a date, a time, and a place, and we report variances, or you have to count shift to shift. Now, in a world where at Bethany, Brandon, where you have a lot of people on scheduled tramadol, scheduled Ativan, et cetera, that becomes a big encumbrance. So it's good to use the system, but you must use it correctly. Make sure you're doing counts or you're reporting any variances.
Thank you.
I'll just start carrying this with me. I can't stop walking. Whoever said Mark wasn't loud enough? That's just crazy. I'll try and stand this for a little more. Storage. When you sign into a medication cart, when you come onto a ship, you are the responsible party. You now own that process. You own the ownership of the meds that are in the cart when you take the keys. Until the next shift starts, until somebody takes those keys away, you're responsible for the counts and the medications that are in there. Who should be counting that when you're doing a side-by-side count? If you're taking responsibility, you want the other person to tell you there's 14 tramadol in there? Or do you want to look and say there's 14 tramadol? If you are accepting the keys, you should be doing the counting. And if you're verifying with the person going off, which is best practice, they should be the one saying 14, yes. But I was the one counting. Okay? Every time. If you have split shifts, Katie talks 2 people in the splitting. We have an open shift. I can't do all of it, but I can do the first half. That's good. I got somebody else to do the second half. You do an extra count. It is not shift to shift per 8 hours or 12 hours. It is shift to shift based on, I have the keys now, so I'm in my shift. Somebody goes home ill. As they leave, the new person coming on should do the count and accept the responsibility. That's best practice in long-term care. C2s are always in the lockbox. We said that. C3s are, PRNs are always in the lockbox. C3 through 5 routinely administered, can be in the cart or the lockbox, depending upon whether they're counted by date or not. E-kit is right now a focus of the state. What do I mean by that? Every time the state comes into one of my buildings right now, they are looking at e-kits. Why? For the last 2 years, they haven't been there, and they know that people will back off on correct procedure on something. Hey, that med's right over there. I can just go grab it. Please make sure you're doing your counts. If something's not right, you need to report it. So, yesterday I went to one of the carts and there were 2 controlled substance e-kits in one of them. And we said, why? And they said, no, I was thinking about calling on that. How about if we don't? Let's do better, okay? Don't think about it. Something's not right. You call immediately. You pay it down or you call the pharmacy and say, why do I have 2 of these? So get that solved.
Meadows does not have e-kit.
Meadows does not. Good point. Ready? Ready, Vanna? Vanna's coming. You weren't ready. So going forward, controls that are kept in the refrigerator. And this is a new thing the state just started throwing in. There will be a box that has a key. This will be affixed to the wire rack in the refrigerator, and then it will have a lock. Controlled substances that must be refrigerated need to be kept in a second lock in the refrigerator. So every refrigerator will have one of these beautiful lock boxes. Yeah, you can see it.
Oh. I'm trying.
She did good. She did really good.
Thank you.
Yes. Administration, part of your control, right? You're controlling it, you're administering it, part of, again, 3 parts: receipt, control, and disposition. Administration, obviously you got to get the right person, the right drug, right time, all the time. Especially important with controlled substances because the opioids have a lot of allergies. We can't ever, if we give the wrong drug to the wrong person, it can be a fatal issue. So please make sure we're doing that. Also, there's huge variations in dosing on the opioids. So one person might be on 15 milligrams of morphine and another person could be on 100 milligrams. If you're only on 15 and you get 100, you could stop breathing. Right person, right drug, very important with the controlled substance. And then document. If I could say there was one issue that I would like to fix, it's documentation of PRN medication, right? It's a problem. It is an ongoing problem in every building I've ever been in. I've never seen a facility that did exceptional at PRN documentation. And I'm going to say it was part of the write-up, okay? Part of the write-up was follow up on PRNs. It's going to be here, it's going to be ongoing. How do we fix it? I can't. I don't have a way. You have a, Bethany Brandon has an electronic medical record system, which requires you to follow up, right? So it's better. Still very, if I went in and looked at responses to why something was given and how effective it was, I bet I would see almost identical lingo every time, rather than truly doing the pre-assessment and the post-assessment for payment and what it amounts to. Please make sure you're doing that. The person deserves that. The state looks at that. We want you to be accurate. Refusal. I have a typo in here, and I'm going to tell you what it is. refusal. If the med's refused, it must be destroyed and documented. So you get up to somebody, give them the med, it's in the cup, and they say, no, I don't need that pain meds now. I already have it out of the bubble. My typo is that is not called destruction. That is called wasting. And we get into some minute terminology things, but the reason to say that is the Department of Health and CMS consider destruction to be a very specific term. Wasting is a single dose or a part of a dose. A single nurse or med aid can waste the dose. Now, in your policy, it should always be witnessed, and that is good. You should always, if you get to somebody and you have that in the souffle cup and you have to waste that, it should always be witnessed. So you take it, you go, I'm going to flush this. I'd like to watch you, and we're going to both document in the medical record. Perfect. You do not need to get one of your doses of nursing to waste a dose. You do need it if you're going to get rid of the rest of the card or the rest of the body. That's destruction. So partial or a single dose can be wasted by anybody who's authorized to administer with a witness. Reorders are, PRNs are always you're subject to reorder. Please reorder wisely. You know, if somebody's really starting to crash and they're a hospice patient, let's get the med out here earlier. If somebody is surgery and they seem to be using less and less, then maybe hold off, because the last thing we want is too much medication in the building. It's just risk. Last thing, just a note, do not ever use, for those who are in Bethany Grant, do not ever use controlled substances without approval from the pharmacy. We need to make sure there is a valid prescription in place, not a valid order.
When you destroy, or not destroy, when you waste something, it goes into the RX destroyer, not into the sharp box at all. Because you can easily shake a sharp box to get a pill out. So it has to be in the RX destroyer.
Thank you. I haven't seen anybody using a sharps box for destruction for years and years, so it didn't even say valid point. Thank you very much.
So I just want to clarify that if you punch a pill out, you can't tape it back in.
Never do that. If you punch a pill out by accident, then you clearly label what that is, put it in your cart, save it, and talk to nursing at the next opportunity. Okay, we're up to the third section, destruction, disposition. Controlled substances should be disposed of promptly upon death, discontinuation, or discharge. What is promptly? At the next available opportunity. Now, if somebody dies at 2 in the morning, I don't think Katie really wants you to come out and destroy it. Right? That's not reasonable.
I would agree.
Yeah, thank you. Good. Yeah, stated it. However, Stacy said she wants you to call her. No, it's at the next available opportunity. We're changing the process in this, and I talked with both of them. We are no longer going to take that medication off of the cart and give it to them to store until they get somebody that can co-sign it. Because that transfer loses our trackability of that medication. On top of that, I told them, if you leave that on the cart, it will become promptly destroyed, because you guys will hassle them until the end of the day to get over there and destroy it, because you don't want to have to count it again at your shift, right? So it will get done much more promptly than if you handle it, hand it to them, and they go put it in a lockbox, and then they, oh, I'll get to that, and I'll get to that, and I'll get to that. And then it's a week and a half later, and then somebody finally gets to it. But there's potential for loss every time it sits there. And nobody's tracking it, and the state does know if you're tracking that or not. So promptly, keep it on the cart until you've hassled them to the point where you said, okay, I'm gonna come, I'll get rid of it. We'll get rid of it. In South Dakota, you can have nurse or nurse pharmacist in skilled facility. In assisted living, you can have nurse witness. Now, I think we're sticking with nurse at this point for destruction. So that will be in both spots, nurse. Legally, we could go to nurse witness over there, but if there's enough nursing where there's not a need, so that's fine. Again, for Katie's point, it must be a secure and safe method. RX destroyer is the best mechanism for that. Make sure it's getting recorded. And I think I went through. Okay, one last thing. On a rare occasion, something will happen where, for the most part, 99.9% of the time, the pharmacy cannot take back controlled substances once you've signed for it. So you either have to say, I'll give you two examples. One is, you call us and say, I have a resident who's dying, and you stat out the morphine. Yes. A half hour later, the driver's pulling in, and the resident really went fast. At that point, when the driver shows up, you have not accepted the medication. I still own it. That is not a return. That is a refusal. And that should come back to us. Please do not ever fret about saying, I'm sorry, I'm not going to accept that. My resident no longer needs that. Have you return it to the pharmacy? That's okay. That doesn't bother me one bit. I wasted a stat and the driver. No. Why would you want that med in your building? You don't. So if you get to that spot, refuse the medication. Okay, we'll handle it. Second part. On a rare occasion, something will happen where we'll say, we're going to come and pick that up. If that happens, and it's rare, we will send paperwork. There's a whole process to it. Because the DEA really doesn't have an authorized process for us to pick up a medication from a non-DEA registered facility. So we've had to create our own process. And those are rare things, such as somebody ordered the medication last night, not knowing that the resident was going to get transferred over to Bethany, Sioux Falls. And so we're picking it up to deliver it to Bethany, Sioux Falls, something like that. And we shouldn't really be doing that, but we are going to take it, but there's going to be a process to it. So those kind of things will happen. Quality assurance. In amongst all this, and we went through the three parts: receipt, storage, disposition. Now, how do we check to make sure we did those? And that's quality assurance. There's tracking functions, and that's what the survey team looks for. So I can tell you, as part of a plan of correction, it will be in the CLOPI process for the next year at least, and potentially ongoing, to make sure that we're tracking ways that we're doing it. The number one thing I say is we're going to improve our audit process. What does that mean? It means you're going to see a lot more people running around checking to make sure controlled substances are tracked on receipt, on storage, on disposition. And it's not just going to be Katie, and it's not just going to be Stacy. Then they start getting into the routine. Like Anita, she might get pulled in with Stacy to look at something. So, hey, you're going to be my partner today to do this audit. It'd be my part to do the audit today. All right. But the more people who know how to do the audit and are part of the audit, the more eyes, the more, and so we highly recommend it. It's a two-person process. It happens frequently and it happens quickly. We're going to take a half hour. We're going to go audit 6 things and we're going to be done. But those 6 things are going to change and they're going to be in different locations. Sometimes we're going to be really looking focused on receipt, and other times we're going to be focused on disposition. And it's going to be routine. And we're going to make sure that everybody in the building knows we pay attention to controlled substances because CMS says we have to. It's the right thing to do, and it improves resident safety. That's the real big thing. What are we going to be looking at? Receipt, shift to shift, reorder process. So when I say reorder process, that one example I gave you where somebody said, why did we receive this? The reorder process was flawed. Because the person who was ordering the med was ordering it when they were the only person who could receive it. We'll watch for that. We'll look. How many times did the order come through? And again, you have different shifts. But so, for example, did the order always come in at 4 o'clock? So to us, so that it showed up at the pharmacy, or out here at the facility, showed up at the pharmacy at 4 o'clock, came out here at 6:30, and it's the same person on. If that's 90% of the time, they'll go, that's an ordering flaw, because that's not normal. Disposition process and random audits using pharmacy data. In other words, we present data to them on what we send. It should match up with what's received and what's gotten rid of. In addition, we found a nice report in Point Click Care for you. You can use now, and you'll be able to use some point, that will show the following controlled substances were discontinued, and I either remember or can check that every one of those was disposed of correctly. So, got lost, improved system, nice audit system. Again, every discrepancy needs to be reported. And if I said, I actually challenge them to tell me how many times in our system have you been reported to that a pill was missing on a controlled substance? 1 pill is missing. It has to meet to them. It can't just come to us. Hey, you had an empty bubble on the 23rd. Could have been pharmacy there, right? We can have an empty bubble. It happens. But if it's our error, it still has to be reported so that it's a double check on the investigation. So please make sure you're doing that. Thank you for that. Because it helps our quality. We can look at those. Hospice. You've had an increase in hospice, right? That's what I heard.
Meadows leave.
On the assisted living side. I've been complaining about hospice for 5 years at a minimum because hospice changed in long-term care about that long. And hospice is great when they're used correctly. A hospice patient, hospice is intended to assist your team, not to take control. You own that patient. You own the responsibility for that patient. You own the meds on that patient. Do not ever turn that over to hospice. They're there to be an assist, be somebody you use as a reference, have conversations with, and to agree on a plan. And obviously that's a little more directed at nursing than the med-aid team. But I'm going to tell you what, for the med-aids in here, how many of you think you're a strong voiced med-aid? How many think you're the loud one in the room, right? I love it. Go.
No.
What should you do? Talk to your nursing and tell them, hey, why would we do that on this patient? And you see that patient, you work with that patient more than anybody else. Way more than anybody else. Don't let the hospice nurse take control of that, and you guys fight for what's right for your patients. Okay? It's really important. All medications should be jointly reviewed and agreed upon. A plan of action should be clear. That's important. And finally, if hospice wants to be proactive and get medications on board, that's great. I don't know what that was, but that was cool. That's, if hospice wants to do that, I don't have any problem with them being proactive. Again, nursing here can take control and say, I'm glad we got that order, but we don't need it yet. So all you have to do is call up the pharmacy and say, you just got that morphine order, please don't send it yet. Because we don't want that in our building until the resident needs it. Profile, it's sitting there, and when nursing needs it, it's available, ready to go. You don't have to go back and get the prescription.
If I could interject there too, that's especially important on the nursing home side. If hospice, if hospice,
She didn't use it.
make sure you're all muted on the computer, please. But if a hospice agency orders, let's say, a PRN anti-anxiety medication, and the resident never touches it, that is still counted in our quality measures for our facility as anti-anxiety medications. So we are held to a standard to try and keep the percentage of our residents who have antipsychotic medication, anxiolytics, all of those things to a low point. So that resident might never take it, but if they have it prescribed to them and it's on their MAR, we get counted for it. So that's one of the major reasons, one, that we need to control the medications that hospice is prescribing to us. Okay? Questions on that?
So to clarify that, if they order it, they have a terminology called profiling it. We can have the order, pharmacy will send it to us till our nursing says, now it's time, and they'll dispense it. So we can put it on profile.
Yeah, I love it, right? I'm always happy when people clarify my stuff and double check. Go, make it clear. Thank you. So, please keep that in mind. I'm not against hospice agencies, but CMS made it very clear in their last regulatory update that the facility owns the patient and their responsibility for it, and hospice is a collaborator.
This slips by nursing and it comes after the nurse is gone for the day, you can refuse it. And let us know, and we'll let pharmacy know that that should have been a profile. So sign for it's now out, right now.
Unless they've talked to you and said, you know, this is coming. You know, if you know it should be there, or if you're not sure, give Stacy or the nurse on call a call. Self-administration policy is going to change. And again, as Hunter referenced earlier, self-administration is one of the areas where we kind of got some issues, especially over on the assisted living side. So we're going to do some work on improving the self-administration form. We're going to do limited quantities. So we will not put full quantities in a resident room for them to have to sell. We would put a quantity in a room that would be safe if a resident decided through confusion or dementia, I'm going to take all these. We would make sure it wouldn't be a lethal dose. And we're going to put a policy in that there's twice weekly audits or comps. So nobody can go more than 4 days without having an audit or count by somebody authorized. So if we need to, does not have to be a nurse, a med aid could go in and count how many tablets there are. Med aid's responsibility is, well, I had 12 yesterday and I have 2 today. I'm gonna get that card out of the room and talk to the nurse. And let nursing take control.
So we're still, go ahead. Yep.
I'm just gonna ask, because I came from a different place where even if they used to self-administer, we still had it. You know, we took it in, we kept control of it, because they're here anyway. Why are they self-administering? Why can't we just do like we do for everybody else and give them their bills?
That's a great question.
Like if there's like say they get an extra one in between, get the old pendant, and then we can give them the extra one in between.
Because that is a resident right in the state of South Dakota. The residents have a right to self-administer their medications if through our assessment it is found they are safe to do that. So that's the big reason why they do that. It would be a lot easier if we could just have control over it. But coming into a facility, the state of South Dakota is very, very, very keen on making sure that those residents maintain those semblances of independence that they had before they came into the facility. I just want to touch a little bit on the main thing you're going to see in terms of self-administration. This isn't necessarily a problem on the nursing home side. I don't think we have anybody who's self-administering their medication. But if residents on the assisted living roster at Bethany Meadows have an order for self-administration and a narcotic is on there, we are either going to be storing that narcotic or the resident needs to provide storage options that they only have access to. So no longer will there just be free narcotic medication in a resident's room. All of that narcotic medication that a resident is self-administering will be placed behind a lockbox, either in a safe or other safe storage device. Because that was what we ran into with this most recent incident. She kept Xanax in her bathroom drawer and 2 cards of it went missing. So that's also to Mark's point, why we're reducing the number of medications that can be allowed to be kept in a room. There's no reason that she had 90 Xanax pills in her room. So that'll be the main change you see with narcotic distribution for self-administration.
I think we'll just tighten up, again, I put on their self-assessment form. And I gave a quick example to the team when I was talking with them on Tuesday. I said, you know, it's not enough that the resident should be able to tell us what they're using the medication for and how to use it correctly. The next question is, why do you feel like you need to do that yourself? And if they can't give a clear indication to that, then there's a reason to withhold that. So very important. I think there are some really good spots for self-administration. You know, again, medication over therapy every time. Let's get some more biofreeze on them and they'll be fine. I'm just teasing. I love teasing therapists. My daughter's a physical therapist, and I've had the opportunity to co-present with her many times, and we always have this ongoing rivalry and tease each other about stuff like that. So you got stuck. That's the end of my slides. And for those who've heard me before, I usually try to get family pictures in, but this was a rush. I got to see a picture of Hunter's daughter the other day. None of my kids or grandkids are that cute. So I just, questions to this point. I thank you for all the questions during the presentation. That was incredible. That was very helpful. Last thing I always leave everybody with. This is you're either a certified med aid or you're a nurse, right? And your career, your job right now depends on doing things. At any point, when you mess up on any of the things we talked about, it could be a career-ending decision. And my example is my wife by training as a nurse. She's been a mom and a grandma for the last 30 years, but she did nursing right out of school. She came home one night very disturbed. There was a count that was off by one pill. And somebody finally said, yeah, I remember giving that now. And they signed off that they gave it. Because they wanted to go home. But they didn't give it. Somebody else said, came later, I went, no, I don't know what he's talking about. I gave that medication. I'm sorry I missed the first part of this meeting. Now he falsified a narcotic record, nursing license suspended, loses his job. We just keep it simple. Do it right, do it up front. It's very easy. Just never want that for anybody to be in that predicament where a license, a career, all the things you work so hard for ever get in jeopardy. This is pretty straightforward. Just do it right. Okay? They'll give you the time to do it right. They'll make sure they'll support you in that. I really got that. The other thing I would finish with is we were missing 7 Xanax in a big building over a long period. This was one of the best reviews I've ever done. And I told you guys that. This was one of the best reviews I've ever done. You're doing so much right. Keep doing it right. Part of Hunter's responsibility is during an audit, something like this. He has to do an education like this and put things in place immediately, or buildings can get penalized. So the second it happens, he's got to take action and say, we're doing training and getting it in as soon as possible. Even if at the end of it, we found there was no problem. You guys are doing things really, really well. Keep doing things. Thanks for your diligence. Thanks for taking care of people better than anybody else does. Because I can see it when I'm looking through stuff. Good work. Appreciate it. And now I feel like I'm going to get roasted by the therapist.
I think one of the most important things I just want to mention is if at any point you feel not confident in something in your administration of medications, you feel anything is off, please go to your leadership. If Stacy's not in the building, go to Cynthia. If Cynthia is not in the building, if Stacy's not in the building, come to Katie. If the 3 of them are in the building, come to me. My cell phone number is posted. If it's an emergency or you feel like, man, this is not looking good, always notify. When in doubt, report. When in doubt, report. Because if you don't, like Mark said to that point, that's where we might run into different issues, okay? So always, always, always let us know what's going on. Okay?
How come it hasn't been audited?
Would they be? If there's something then, because you can't track the cream.
I would say it'd be more just not for the pill forms of those medications. Yeah.
Dana, did you hear that?
It would be
Yes,
like
I did.
the pill forms of those medications.
Okay, sounds good.
Okay.
Thanks.
All right. Well, thank you, Mark. I appreciate it. Is that all they're seeing? Good. Stop sharing this.
Go back.
Oh, yeah, just there. Okay.
Okay, we are going to move right into the second part of our educational session here. This is something that we should all be familiar with, specifically the staff at the Bethany Home branded side. We're going to be touching base on skin, care for skin issues and pressure ulcers. Now, I do want to mention, as Mark said, when it comes to documentation, that is where we're seeing a lot of the issues when it comes to our skin care, okay? And to be frank with you, we went through the full survey process 3 years ago. I know some of you were here with that. where we, to be frank, just got reamed because of our pressure ulcer care in our building. We had a lot of them, we weren't documented appropriately, and we weren't following up with the interventions that were in place. And we got a G tag for that in our federal survey, which is one of the most severe tags you can get in a survey. And as a result of that, our facility was fined $30,000 because of the tags that can be administered as a result of this. So when Mark says it's my responsibility to start immediate education, that's not just after a survey. So it was brought to our attention on our rounds at Bethany Home Brandon that we had 10 residents with a pressure ulcer. That's 20% of our total population. Frankly, that's unacceptable, and we need to start making immediate changes to try and remedy that situation. So today, we are hitting a reset button. We're going to go over our policies and procedures of what needs to be included in our skin documentation. Our dietitian is here. She's going to give some education on how important it is to follow our diet orders for skin integrity. Polly from Good Care Rehab is here to talk about how rehab can play a role in healing pressure ulcers. And then Katie and Stacy are going to touch on the things that they expect to see and what they are doing to audit these pressure ulcers, okay? And it's not just pressure ulcers, it's any skin concern. Any skin concern that you see, and we'll talk about this later, much like a medication that's missing, needs to be reported to your nurse or the DON. Okay? So we'll start here with our dietitian, Angie Miller. And she's a contractor with us for both Meadows and the home side. I'm sure you guys have seen her around. So let's give Angie a warm welcome.
All right, like Hunter said, I'm Angie, the dietitian, and I go to Angie.
Can you stand closer to the computer?
I was hoping not to get on the camera, so I love this, but I was watching in the back. I'm Angie, the dietitian, so I go to the home side weekly, and I go to the assisted side once or twice a month, just depending on the need. And one portion I want to talk about is the pressure injury. So nutrition plays a huge role, not only in pressure injuries, but our whole body functions. So nutrition affects every cell in the body to make our heart go, make our lungs go, digestion. So in skin is the largest organ in the body. So you think about when we have a breakdown, such as a pressure injury, how much nutrition has to go to that? Because there's so many cells within that to heal. Nutrition is important to repair the body's organs. One of the main things I want to talk about is calories, protein, and then fluids. That's the three major things I look at as we're looking at a pressure injury. So for a pressure injury, we need extra protein to heal that. And not only does it heal it, but you think about, say, if we have protein and we're not really eating, we can give somebody as much protein as 3 ounces per meal, say. And if it's not enough calories for that person to survive or keep their weight stable, we will not heal that pressure injury. It doesn't matter how much protein we get in if we don't have the adequate calories. Does that make sense? Yeah. Okay, so I think of like protein as a building block to that. So we think of calories as our base and then the protein to help build that skin integrity. Other things that I look at are nutrition supplements. And nutrition supplements provide conditionally essential amino acids. So a lot of times you may see if somebody has a pressure injury, I'm recommending arginine. I don't know if you guys have seen that before, or like a vitamin C or a multivitamin. And if a resident isn't consistently eating that 75% mark or greater, they're going to need a supplement to help heal that, because our nutrition, if we're eating even 75%, goes right away to make our organs function, that heart, the lungs, the digestion, and all those products. So a lot of times when they have a skin concern, we need to bulk up those calories so that it does help heal that wound. So sometimes we might see somebody that is overweight, and you might think it's silly that we're putting on some kind of nutrition supplement or, giving them a little boost of protein. But I do tell you it is needed. And if it is in your orders, again, please make sure it's given. It's given for a reason. And you can look back on my note, maybe I will spell out why. But it's very important to be given the extra calories and protein as well as fluids. So that's another reason why I like the supplements, is because it also gives fluids, and fluids are what help carry those amino acids to that wound. So if they don't have enough fluids, again, it won't all go to the wound either to heal.
It's not as necessarily dire to, like if someone doesn't take a narcotic medication, we need to obviously note that. If someone is refusing their extra supplements, that is something that should be communicated to your nurse manager, to the nurse, so then we can then communicate that to Angie. So it's much like administering medications when you are administering a supplement.
Yeah, and I think of that a lot of times too, as I explain, like if we so like a nutrition supplements order, such as like an insert, well, that's chosen over, say, 206 juice or a mighty shake for a reason. And so if we're subbing that, just like a medication, we wouldn't sub maybe ibuprofen if they didn't have a Tylenol order, right? So we wouldn't sub a Zofran for another medication that we would have on board. We would always give the medication that's ordered, right? Okay, and that's how I want you guys to think about supplements as well, or a food item that is ordered. It's ordered for a reason, and so it's really important that I want them to have that to help with the wound healing. Other things I want to talk about. So at Bethany here, we have nutrition supplements for dietitian. So when they come in on the standing order, then that allows me to write any kind of supplement order. Yep. So usually at the end of like the assisted living side, I have to send an update to Crystal and Stacy, and then the recommendation to both Pat and Lori, you do the regimen that's recommended. And then also I want to say that just like any human, we're all built a little differently, right? So I think of not one fits all for everybody. So one thing of that is a kidney disease resident that we may not want to push protein because that causes more stress on their kidneys. But my job is to go and provide them that education and allow them to choose if they want to push the healing on it and possibly cause more stress on those kidneys, or to go the opposite way and kind of be do less protein just to not answer. So again, one size doesn't fit all. The other things that I look at are blood sugar levels. So very important. If a wound is not healing, of course, the blood sugars are high, we want to manage those first. Hospice, as the pharmacist said too, is a lot of times I may make recommendations and nursing may butt heads with me, which is good because I like when there's two strong personalities that are trying to do their own disciplines. Is like end of life. I may recommend something that the nursing team maybe doesn't think at the end of life is important. Putting on a multivitamin, which seems maybe silly, or doing more supplements or doing the arginine. But again, that's my recommendation. And then if they don't want to do that, or they choose like, I'm thinking of somebody on Plum who is end of life, and she's like, I don't want any of that anymore. And it's just offering and giving them the education, but then also allowing them to make their own choices. And then another statistic that I found was pretty interesting is there's about 15 to 25% of residents admitted to long-term care that do have a pressure injury. They're at more risk as they stay long-term within the facility, and that it costs anywhere from $10,000 to $40,000 per resident to heal a pressure injury. And that would be with like medications, more nursing staff, myself taking time, these type of meetings, of course, medications to help with the healing. Then I also want to just briefly talk about a few other things that do affect the nutritional intake of residents. that also can affect if we're not considering these things, we can see skin breakdown as well or poor nutrition quality. So I feel like it's an important topic as well. As we age, lean body mass decreases, our muscle mass decreases, our fat mass actually increases. Bone density decreases, our fluid sensation decreases, we're more at risk for dehydration. So pushing those fluids is very important again. Taste buds decrease as we age. The GI system slows down with gastroparesis or just natural aging. And then dental problems increase, which can cause a decline in our nutrition intake, which then can cause malnutrition, which can also put us at risk for skin breakdown. Unplanned weight loss and malnutrition puts a resident at risk, decrease in ability to fight infections, and ultimately premature death. 7 out of 10 nursing home residents fail to finish about 75% of their food. Again, going back to that first little topic we talked about, if a resident is not eating at least 75% of their needs, they're going to need some type of nutritional supplement to help boost that so that their body can function, their heart, their lungs, all their functions to keep their skin intact as well. One thing that I talked to the kitchen about is making sure things that we can do is make sure that their meat is tender, their food is cut up. So if you're out there serving a meal or helping with meal service, is make sure you just cut up their meat for them. Ask, sir, can I do that for you? They're going to eat more, which is going to help them thrive long term. Again, that goes with their chewing problems or dentation as well. Special diets and consistencies are very important. And I feel like we've done very well with that. But that if somebody's on a mechanically altered diet, that we are giving that actual diet because they are going to take more. There's a need for that diet, whether they have MS, Parkinson's, poor dentation, they've had a stroke, whatever the need is that we're accommodating. Again, it's just like a medication. We're treating a disease process with nutrition instead of a medication. And then the other thing I want to talk about is behavioral problems such as pacing, wandering. I can think of a couple residents in memory care that do that will need those extra calories. If you guys have ever heard of Parkinson's disease process, sometimes residents that have those extra tremors and body functions going on, they may need up to 5,000 to 10,000 extra calories a day versus the food that we're already giving them. Inability to communicate. A lot of times if we contact family, they can tell us some of their food preferences that they once loved, and we can accommodate that into their meal plan. A lot of times I do that upon admit or if we see a nutritional decline while they're part of our facility. And that is all I have. I just want to say thank you, and I couldn't do my job without you guys doing your job. So everything I feel like relies on nursing. And so I really appreciate it when there's a supplement order that it is given to them or communicated to me that, hey, this resident is telling me, at night they don't want it anymore. And we can come up with an alternative. So thank you for the communication.
Thank you, Angie. Okay, next we'll have Polly from Good Care come up and talk to you a little bit about the role of physical therapy, occupational therapy, and speech therapy in pressure ulcer healing and wound management. So it's going to be Polly on the clock. You guys all have that handout she brought, right? Okay.
I created this handout, and I'm basically just going to talk about that handout and what you can do as a nursing team before therapy gets involved, and then how we can help support you because we are here in the building on a daily basis. So I am an occupational therapist by trade, and I've had my OT lessons for 20 some years. And so I've been in long-term care since I was 16. I started off as a CNA, worked my way through school, and I have been in long-term care since since 16, and I love what I do with long-term care residents. And I've seen a lot of wounds, and I've seen a lot of things that we can do as a team to help promote wellness and to reduce skin breakdown and to help those residents live on a higher quality life. So I kind of just wanted to talk, and I would tap into what the dietitian has just said, because that's one of the key things that we help work with our speech therapy team, and even with our occupational therapy team. When you're seeing those nutritional declines, maybe a resident isn't eating as much as they used to, or they're having weight loss, along with the dietitian, you can get our team involved to look at the textures of food, what kind of ways that a patient might be feeding themselves. And maybe they're not eating because they want to be able to feed themselves, they don't want somebody to feed them. And we can offer those kinds of support as well. For those residents that are in memory care and are constantly on the go, offering finger foods as they're on the go might help with that caloric intake. Giving them a ham sandwich while they're walking around because they don't want to sit down and eat. Because all of those nutritional factors do play a significant role in how their skin integrity can remain intact. As that skin integrity is lost, as they lose that fat, bony prominences are more they're more evident in those patients. So I do have pictures here on your sheet that kind of show the different areas of bony prominences that we generally see when there are wounds. On the little gentleman with the red dots, you can see like the back of the head is an area that is of concern. Along the spine is also an area of bony prominences that tend to have different types of skin breakdown. Across the pelvis, in the bony hips, on the joints, on elbows, on heels. So it's looking at all of those areas and how are we helping to get that pressure off of those bony prominences? Are we repositioning as we should be every couple of hours? Maybe it needs to be more often if they're a small, frail little lady who just can't stay in one position for more than an hour. Kind of be mindful. You'll see those reddened spots that will occur to begin with, and that is your red flag that there's something occurring in their skin, and that something underlying is starting to cause a skincare issue. So we want to be looking at that. When you're doing your baths, if you're looking at those areas on their skin as you're washing them, paying attention to those areas. When you're helping them get dressed in the morning, you're the first people that see those different areas of skin that we might not see on a daily basis. So being really evident of that, talking with your nursing team, getting us involved, we can come take a peek. We don't need an order to take a peek. If we see that this looks like a concern, you can definitely get PT or OT involved to help you with figuring out a repositioning protocol or techniques that help get them up from those bony areas. Making sure that we are keeping wrinkles on the sheets, and maybe the head of the bed should be elevated. So things that are maybe things that come easy to us, and you've got enough things to think about during the day, maybe those are things that we can help with. But even when you're not using the services of a therapist to begin with, if you just wanted to try and bring those skin issues down from a lesser intensity on your own, ensuring that you're not doing a lot of friction or shearing when you're moving a resident, especially if you're slapping somebody with a sore coccyx or across their heels, they're not rubbing on the bed. Making sure they've got the right shoes. That might be an issue, that this patient hasn't had a new pair of shoes for 5 years, and you know how the heels break down on your shoes, and that could be rubbing on those residents' heels as well. Adding those barrier cleans, ensuring that you're putting all of those products on coccyx or, you know, during your toileting tasks. Looking at wheelchair cushions, that's an area that we are very good at. You want to make sure you're only using one cushion in a chair. Sometimes you see where there's a couple of cushions in the chair, or maybe there should be a cushion in a recliner, or maybe there should be a cushion in a recliner. There's different things that we can look at. How often are they staying in that wheelchair? I mean, you've been sitting here now for almost an hour and a half. How many times have you repositioned yourself and shifted your weight and got your hips in different positions? A lot of these residents can't do that, and they need us to help them do that. They're not strong enough. Can you imagine having to sit here for an hour and a half and not try and reposition yourself and shift yourself? So you have to think of some of those things when you see your residents that are at a dining room table for maybe an hour. Then it's time to maybe move them into a regular chair or a recliner, or they lay down. And when they lay down, that they're on their side every couple of hours, not just in their bed. And they may be quiet as can be. And that's great. And you don't have to worry about them because, I got all these other people who are causing all of this other chaos, and Edna is doing great just laying there. God, those silent little immobile residents are the quiet ones that their skin is going to be irritated and causes issues later on. So taking that time to do a 5-minute reposition, or taking that time to work with another staff member to get a resident out of a chair and into a different position. All of those things play a big key factor in the time you're going to take later when you've got 10 wounds that you now have to try and address and heal, and spend that extra time with that. And those are red flags. The state is going to be looking at those. Those are huge issues that they want to see fixed. They don't want to see in the buildings. And we want to do whatever we can for these residents, because we are the care providers and we are here to give them everything that they need to be in a safe environment, to be and stress-free as possible. So another thing that I want to talk about is incontinence. You know, incontinence is such a big issue for us in long-term care, and ensuring that those briefs, even with somebody that has some skin integrity issues, even if that brief does not feel like it is very wet and it could go maybe for another hour, that just that acidic nature of urine on their skin can really do a lot of damage to their skin in just a short amount of time. So we want to be sensitive to monitoring and changing up pads and keeping them their skin as clean as possible. So we're here, PTOT and speech. You've got a great team out here. If there's any ways that we can help you to, monitor these wounds, usually we don't get involved with the wound until they are a stage 3 wound. I think right now they're stages 1 and 2, but we can still be on board as their therapist for pain management, for repositioning, for strengthening, for range of motion, for wheelchair positioning. So there's other things that we can do to help you to bring down your wounds in your building.
If somebody's employer was leaving a sling under their legs, they should be rolled up.
Well, the sling should be removed completely from a resident. They should not be kept on them at all. I know when you've got your very obese and very difficult residents that is hard to reposition a sling, but truly it is not meant to stay underneath that resident for the whole or for the day at all. It's supposed to be removed once the transfer is completed. Any other questions? Feel free to stop by, let us know if there's any questions. Bring us into a room with a resident and we would be happy to help you.
This is a great opportunity for therapy to get involved. You know, If someone's becoming less mobile, you know, they're going to be sitting down more. They might just lay in bed. You know, those are the things we need to start noticing so therapy can get involved early to try and help with some physical therapy or occupational therapy. The main thing I want to stress when it comes to pressure ulcers is how interconnected they are to every single department, but especially nursing. I mean, if a person's not eating enough, they're going to be tired. So they're going to get weak and they're going to lay in bed. And their physical function is going to decrease. And then they're going to get a pressure ulcer. So our bodies, all of these different, all of these different disciplines. So dietary, physical therapy, occupational therapy, speech therapy, nursing, all need to work together to try and prevent these. It's not any one individual department's job. However, nursing has the biggest onus because you're the one seeing our residents every day, noticing those slight changes in skin condition, noticing if they're not as physically functional as they used to be, noticing if they're not eating enough. That's where we need to be vigilant and observant. So always consult with your therapist. They're here every day. So stop them in the hall. Awesome. Thank you, Polly. Hey, just let me ask you this. Does everyone know what a pressure ulcer is? Yes? Shaking your heads up and down? Yes? Okay. How many stages of there could there potentially be for pressure ulcers? Unstageable is the last one. So 1, 2, 3, 4, unstageable. So I might have my nursing staff kind of touch on what the definitions of each of those are, if you wouldn't mind. Hold up. But I do want our directors of nursing to come up and just talk about what we are trying to do out here at Bethany in terms of our policies and procedures to try and prevent pressure ulcers and what the expectations are in terms of our documentation that we have for our pressure ulcers and skin concerns. Okay, so let's give your DONs a nice round of applause.
I guess from a medical perspective, you don't see this quite as often because our residents are obviously more mobile, right? So we partner with Shannon with AAP, and then nursing does rounds regularly. But we still, echo what Hunter said, rely on our CNAs and med aids. If you're hearing your residents say, you know, something's wrong with my foot, we've had a lot of toenail issues that have led to foot skin breakdown and other issues. If you're bathing them and you're seeing like their butt's pretty pink or purplish, that's a sign of skin breaking down, and that's concerning. But overall, I think we do a really good job in reporting those.
All right, I was put on the spot for all those stages. Thanks, Hunter. On the home side, we are skin issues. Obviously, our residents are not as mobile as it is for metal. We see a lot, and we also have a lot of confidence over there too. So, like pulling out and fresh out repositioning like that, everything is very important. Our skin assessment procedure over on, I don't know what yours is, but we do, the nurses do a skin assessment one time a week on our website. And that is, the nurse needs to visualize the resident. So if you guys, if the CMAs, if you guys are giving them a bath, make sure to let your nurse know, hey, I'm giving this person a bath, will you come in and look at their skin? It's a team effort. If you're giving a bath and you notice a red area on and see the bottom, please go to your nurse and voice this concern. Even let your nurse managers know. The nurse managers are very involved in the skincare over on the home side. And so, or grabbing me, let me know. We want to make sure we can do whatever we can to prevent skin breakdown. It's not fun having a sore on your heel or your bottom. I mean, think about that, just sitting here and you had a sore on your bottom. How's that going to feel? So, and then also we do wound rounds once a week. And as for myself and the nurse manager, go around and we assess every resident who has a wound, or any, major skin concern. And we document on that weekly. And then if there needs to be order changes or anything like that, we go ahead and notify the physician of that. Something with order changes, if you have a pressure ulcer and you have a, treatment in place for more than 14 days, you see no improvement, it's a regulation that that treatment has to change. Because obviously there's no point in keeping the third treatment if it's not working. And then,
And like just to piggyback off of that, if you notice that before 14 days, that the pressure ulcer is getting worse, that needs to be brought forward and an order can be changed before 14 days. If it's staying the same, you know, and we're assessing it and it's not getting worse, it might take some time for that treatment to start working. But if you notice that ulcer is starting to get worse, it's got new drainage, it's getting black or necrotic, we need to take immediate action to try to fix that.
I lost my shit. But the nurses, anybody who has pressure ulcer or major skin concern, the nurses have to document that often. Document on it daily. If it's a dressing change, it's not change. It's in order for skin prep and Methylex, and it's to change every 3 days, then obviously you're not gonna take that bandage off every day to look at it. But you need to assess that bandage. Is it intact? Does it need to be changed? Is there drainage? Is it starting to come off? Does it need anything? And making sure we document all of that in a progress note. And what needs to be included in the progress note is what the wound looks like, its appearance, characteristics, drainage. Is there any odor? Once the odor starts to come back, is when infection starts. And infection in a pressure ulcer on your heel or coccyx can very quickly get to the bone, and then you have osteomyelitis, which is a whole other issue where you need IV antibiotics for 4 to 6 weeks. And then, so the appearance, drainage, smell, and then, if there doesn't have pain with the dressing change. If you notice that they're having pain with the dressing change, we need to pre-medicate them before we do a dressing change to help prevent that pain. Anything? Anything? No, I'm not safe yet.
So, yes, I just have something I wanted to express, I can't remember it now, so we continue and I'll jump in.
Okay. Then, when you're doing your skin assessment, that are done weekly, please don't put no new concern. A skin assessment is an assessment you complete as a licensed. Put their skin is dry, their skin is warm, intact, no open areas, or maybe they have small burns, not healed, or multiple standard bruises on their arm. Even though that's normal for them, because in older adults that is normal. Make sure to put that in your note, even if it is something normal for them. What is your skin process?
Our current skin process, is that, if we find something discoverable, either from floor nursing, a surgical procedure, a fall, a transfer in, we do a full head to toe assessment of every new resident or readmission after 5 days of hospitalization. We follow strict doctor's orders on when we're changing them. I think that we are rounding every day on wounds, but there are specific resident guided wound changes. We, like I said before, we partner with Shannon. We do once a month on all wounds.
Shannon, sorry. I think I just heard someone say who's Shannon. Shannon is a representative from a company called AMT, and they specialize in treatments. So she's a nurse, correct?
Is actually a physical therapist by training.
Oh, there you go. Yeah.
She's the nurse at
PTs are heavily involved in that stuff, so.
So once a month, she comes and she helps with our supplies, getting physician orders. She kind of helps bridge our nursing resources for our own family. It's not nearly as intense, but I don't think we've had anything quite as severe as going to like blood and pressure two or I think minimal. But that doesn't mean that we don't, even if it's ordered for 3 days for changes, that we're still not seeing it every day, especially when we got a lot of drainage and, you know, like Katie already kind of reiterated, a lot of things are mimicked, we just don't have the severity that we see quite as often. As potential SARS are just more mobile, right? But we saw nutrition deficits, we saw pacers and memory care, all of those things are very applicable to our time.
An example of something that could happen on the assisted living side. I won't say the resident's name, but the resident had a fall and got a big laceration in her leg. I'm not sure what happened, but then she came down to our side and her pant leg was completely soaked with drainage from that. So we had to go in and see what was going on, and she had to get a skin graft. She had to come down to the home side for med aid. It was a very big process for this resident. So even those major lacerations that happen from falls, if we're not looking at those frequently, they can get out of control pretty quickly. So any of those wounds are something that we can see more on the assisted living side with falls or scrapes or something along those lines. So not necessarily pressure, but skin injuries.
Bumping into a table, are they diabetic? Do they have a vascular process? That minor abrasion or wounds can end up in so yeah, no slight wound, I'll just kind of circumference all of it with a scratch or anything. But this guard, oh, yeah, he bumped it yesterday, so I'm sure.
All right, also, that we also, if we have an admission or they come back from the hospital, we also do a skin assessment every shift for 3 days. Just to make sure, because when they go to the hospital, a lot of times they just kind of lay in the hospital bed, and then when they come back to us, you know, something can pop up pretty quick. Otherwise, I'll go over the stages here quick. So stage one, the wound is not open. The skin is usually red. If you go up, touch on it, you know, you touch your hand, you see it blanch. The wound will not blanch. It will stay red. It won't blanching. And it's usually, if you feel it, it's usually warmer to the touch than what the regular. The skin surrounding it. Stage two is where that open, or where that area breaks open, and forms an ulcer. The sore can expand deeper. Usually it's just like the first few layers. It can go down deeper, and that's where we get to our deeper stage, or our stage three, and that's deep tissue. You can see that some of the fat cells start to show. And we get to stage four, that's where you can, it's very deep, you can see the muscle, the tendon, and it can get down to the bone.
We use tunneling quite a bit. Even though like the surface area might only be maybe a thumbnail even, it can tunnel down to the bone.
Or sideways.
Yeah.
And then there is, it's called unstageable. And that's just where it's eschar, it's that black necrotic tissue over the wound. You have no idea what that base of the wound is. So that's how we call it unstable. There's also one more, it's called DTI, the deep tissue injury. It is when there isn't an open area, but the tissues underneath
have been damaged, and so that looks like it's really, it's like, you can tell it's like purple, dark red, and you can tell it's almost like blister-like, but it doesn't have like that fluid in there. It has like the paint over it. And then usually that ETI will open into a stage 2. But I think that's it, unless anybody has questions, or did I miss anything you want me to add?
No, one thing I just really want to stress, I want this to be a part of our daily conversations. We should have an acute knowledge as nursing staff, who has skin issues, who has pressure ulcers. So when we come on our rounds, those are going to be questions that we ask you. And it's not just the nurses, it's going to be our nurse aides, our med aides. Who has a skin issue? Who has a pressure ulcer? Pressure ulcers especially. It should be a daily part of your shift-to-shift handoffs and your communications, saying, hey, as I was getting, Beverly up, I noticed that she had a new red area on her bottom. Let's keep an eye on that. Telling your nurses. If we don't communicate it, that's when things get out of hand. So we want to make sure we try to catch these as soon as possible. And we do that through our observations, through your assessments, keeping a close eye when you're changing and bathing, and through communication, letting somebody know about it, and then treatment, okay? Observe, communicate, and treat is what we want to do whenever we find skin issues. So let's make it a goal of ours to talk about this every single day.
It's same thing, sorry, interrupting, same thing, like, this is a license thing too. If you didn't do the dressing change, or put the wrong treatment on and made that pressure ulcer worse, and it got infected, and then now we're in osteomyelitis, that was like neglect for that resident. So it's important to follow the orders if you're doing your treatments. A whole, something that you guys should be doing is when you put the patch on, date it, initial it. That way you know, I put that patch on that day. And when you come back 2 days later, if that patch is still there, you notify us right away.
One of the most common ones, like Katie said earlier, is when a nurse documents no new concerns. Anytime I see no new skin concerns, we almost immediately go to the resident to see what's going on, because I can almost guarantee you there was a skin concern, or there was a skin change, or there was a worsening of that pressure ulcer. So we should never have one-line documentation of no new skin concerns. It needs to be detailed. Okay? All right, let's make sure that we stay attentive to these things. Like Mark said, want to communicate the seriousness of these things. If we would have had our state survey at Bethany Home Brandon last week when we discovered this, it would not have been good. I'm guessing we would have had another fine. So we need to make sure that we get these issues resolved. So make it a part of your daily conversations. Okay? Does anybody have any final questions regarding the topics that were discussed today? Okay. Thank you all very much. We appreciate it. Have a great day.
Thank you guys for all that you do. I know these are hard topics, but
Oh, you don't need to clap.